So we will now move on to the inflammation after the infection, which is again one of the major chunk of the orbital diseases that we see. And we all are aware about the cardinal signs when we label any pathology as inflammation. The hot, red, swollen, painful, and loss of function, and we have all read it in pathology. We just spoke about infections, and this is a young guy who has a hot, red, painful, swollen orbit with loss of ocular movements, and we do see a mass lesion in the orbit. Now, it fits into the criteria of the orbital inflammation, but he does not respond to the conventional treatment. So what we do next is we do a biopsy and we find fungal granuloma. We have been talking about the fungal infection. So this is a fungal infection of the orbit which presents as an inflammatory pathology. Similar pathology is another young lady, comes with some signs of inflammation of the orbit. There is an inferior orbital mass. Biopsy shows some sort of caseating granuloma, and some other workup for the tuberculosis also turns to be positive. Started on ATT, does not respond, worsens, the orbital mass has increased in size. In the meantime, the eye becomes painful. There is a thinning and perforation of the cornea, eventually leading to an enucleation. And here we see the small vessel vasculitis. Cianca is raised, so we get a specific diagnosis of Wegener granulomatosis. So what we are trying to look at here is this is the inflammation. One had a specific cause like a fungal infection or a foreign body granuloma maybe, which presented with signs of inflammation. And the second one was an inflammation with a specific histopathological features like what we see in Wegener's. And the third category which we usually deal with, the more major chunk, is what we call as non-specific orbital inflammation after everything else is ruled out on biopsy. Now, what we have to be careful is that non-specific inflammation is a diagnosis of exclusion once we have ruled out the specific causes based on clinical features as well as on histopathology. Now, it's not a single disease entity, it's a combination of various disease presentation, but the unifying feature is that they have a very abrupt onset of inflammation, extremely painful, and the sensitivity to the steroid is something which sort of is a common feature in many of these patients. And the imaging will show some either mass lesion of the orbit, and there will be enhancement of the contrast because of the edema in the orbit. But so saying that atypical presentations are possible. According to the patterns of presentation, depending on which structure in the orbit is involved, it could be myositis, dacryoadenitis, and many other involvement. Now, if you see this young girl, she comes with some amount of conjunctival congestion. There was pain on movement of the eyeball. Ocular movements are restricted, as we can see in the right eye, the elevation is restricted, but there is no edema or swelling in the orbit. And now, we are not going to label this as orbital inflammation based on the classical signs, but what we see on CT is a diffuse thickening of the inferior rectus muscle with fuzzy margins, and this thickening is involving the tendon of the muscle. So it was a clinical diagnosis of myositis. We started her on steroid, extremely good response after a few cycles, which again confirms the diagnosis. So the first pattern of inflammation, which is pretty common, is a myositic pattern, which could be acute and subacute or chronic. Like this patient had a subacute presentation, could be one muscle, could be multiple muscle enhancement, but the unifying feature is thickening of the muscle, which tends to involve the tendon of the muscle. Sometimes there can be bilateral involvement, and the most common differential for the myositis remains an active thyroid eye disease, because even an active TED will have signs of inflammation with the thickening of the muscle. But what we see in thyroid thickening is that traditionally is the tendon sparing thickening of the extraocular muscle, which helps us in differentiating. In our setup, Dr. Grover was just talking about cystosarcosis. That is probably the most common cause of myositis, presenting as a myositis with inflammation signs, especially in young adults, which needs to be ruled out and picked up on ultrasound or on imaging findings. Rarely some neoplastic infiltration of the extraocular muscles, like in this gentleman it was lymphoma, can also present like a myositis picture with signs of inflammation, but biopsy again confirms the diagnosis. How do you manage a myositis? If it's a unilateral disease, the first episode, usually there's a good prognosis, conservative treatment is enough, either with non-steroidal, anti-inflammatory, depending on the severity, or with steroid. But if it's an atypical presentation with multiple muscle involvement or a recurrent course, it's best to do a biopsy, rule out any systemic involvement, and treat the patients accordingly. Moving on to the second pattern, this is dacryoadenitis. We all know about the S-shaped deformity of the eyelid. Again, there are signs of inflammation here. Prominent lobe of the gland, pouting lacrimal ducts are again features. And we treat this patient based on the functional involvement of the gland, and the Schummer's value is a reflection of the function of the gland. If the Schummer's is affected too much, if there is a severe dry eye, that means the gland has more severe inflammation, and we tend to be more aggressive with the course of the steroid. Again, dacryoadenitis something is not always a non-specific inflammation, like in this young lady. It's like almost like a mass lesion with a swelling and thicken or enlargement of the gland. Biopsy shows this intertubular fibrosis, lot of inflammatory infiltrate, and her IgG4 and IgG ratio is more than 40%. Serum IgG4 was increased, so that gives us a diagnosis of IgG4 related disease, which is more recently we were not aware of this disease in the very near past, but now more and more diseases are falling in this spectrum as we biopsy more and more of them, and we are aware of the findings. And if you see the review of the literature, there are specific criteria to diagnose them. Many of these earlier inflammation, which were labeled as idiopathic or orbital lymphoid reactive hyperplasia, many of them probably was falling into the spectrum of IgG4 disease. Again, it is important to recognize it because these are more recalcitrant to treatment, needs high dose steroids, and sometimes does not resolve completely with steroid and might need some surgical debulking. Just to also not forget about infection, which can sometimes involve the gland. This gentleman, bilateral dacroadenitis presentation, but on biopsy, we picked up caseating necrosis, and there was actually AFB present and confirming a diagnosis of tubercular involvement. So dacroadenitis can, instead of idiopathic, it can also be present in many bacterial, viral, sometimes neoplastic infiltration like leukemia, lymphoma, and other systemic disease can also mimic it, which needs to be ruled out before you label a patient as a idiopathic dacroadenitis. The third pattern is diffuse involvement of the orbit with all signs of inflammation, but extreme response to steroid. This is just after 1 day of IV methylprednisolone, and we can see the inflammation just gone. But again, here we have to rule out other diseases like a keratoconus fistula, which will be more chronic, but can have chronic inflammation of the orbit. Of course, we are aware about the orbital cellulitis. We just saw some of the pictures. Lymphangioma with bleed can sometimes with an acute orbit, which needs to be one of the differential, and infiltrating tumor needs to be ruled out before we label a patient as an idiopathic diffuse orbital inflammation. The other two patterns, the apical NSOID as well as the perineuritic variant, are less common but can present like an optic neuritis. Like in this young girl, there was a diffuse thickening of the optic nerve sheath, fuzzy orbit, signs of inflammation, again, and very good response to steroid. The last spectrum is a gentleman who has all the signs of inflammation, pain, red orbit, swelling, function is affected, but what we see is a lot of bony destruction and a mass lesion formation in the orbit, which is not a very common feature of orbital inflammation. So what we do here, of course, we do a biopsy, and biopsy shows a sclerosing variant of NSOID, which can sometimes present like a mass lesion with bone destruction also. Unifying feature here is desmoplastic reaction on histopathology, extreme fibrosis on histopath, and these are again the variant which are pretty difficult to treat. This was after IVMP. Now, just to conclude, how do you approach an NSOID? If there are typical features, and it's the first episode, unilateral disease, we treat with NSAIDs or low-dose steroids. Prognosis are good and recurrence are unlikely. If it's a bilateral recurrent disease or any apical or perineuritic involvement, which are more significant, we tend to give high-dose steroid. Immunosuppressants might need to be added up, and we investigate for systemic disease based on the biopsy finding. And close follow-up is indicated because we know there can be recurrence. And if it's an atypical presentation or if we are suspecting a sclerosing variant, we also need to be maybe a little more aggressive with the surgical debulking also at times. So thank you very much.
Thank you, Dr. Sima. That was an excellent overview. I think it's too vast a subject to be covered in such a short time, but you did a great job. Thank you very much. If there are any questions, probably we'll take it at the end.